Hello, my name is Dick Rainsbury. I'm a consultant general and breast surgeon working in the south of England, and my other roles have been as president of the Association of Breast Surgery in the United Kingdom and director of education at the Royal College of Surgeons of England. My interest has been in breast and reconstructive breast surgery for the last 25 years, and today I was asked to talk about selection of patients requiring oncoplastic or considering oncoplastic techniques. And I think the important thing to start with is to say that the multidisciplinary team is absolutely vital in helping people to make decisions, because this is an increasing area of clinical practice. The decisions that need to be made should not be made in isolation with the surgeon and the patient. You need to involve other people like the oncologist, the radiologist, and so forth, because otherwise you may end up going down a path which in the end may be not the best thing for the treatment of the patient. And the key principle in all of this is to treat the patient's cancer, number one, and secondarily, if you can do that without causing deformity or mutilation, then that's all for the good. And the way that I think is helpful to consider this is to divide the treatment into 5 main domains. And one of the first questions you need to ask your patient is, are they happy having a breast-conserving procedure or a mastectomy, rather than having to go through something more complex, which may, in the long run, leave them with a better physical and probably mental outcome. And in order to do this, you really need to consider what the indications for oncoplastic surgery are. And there are 2 main areas. One is in breast-conserving oncoplastic surgery, and the other is in oncoplastic surgery following mastectomy, so breast reconstruction after total mastectomy. The features that need to be considered when you are looking at the need for oncoplastic breast-conserving surgery is, are you going to be taking enough tissue away to justify the patient going through more major procedures? And one of the useful rules of thumb is, if your patient is going to lose more than 1/5 of the volume of the breast, then it's likely that they will benefit from one of the modern types of procedures which will help to make up for that volume loss. So if your patient falls into that group, and there are some quite accurate ways now of defining how much breast tissue needs to be removed, then you need to consider the next domain of decision making, which is whether you're going to put volume back, which is called volume replacement, or whether you're going to readjust the position of the breast tissue and displace it to fill the resection defect, which is called volume displacement. And there are a growing number of different options here, choices for you and the patient and the MDT to make in relation to both volume replacement and volume displacement. And we talked about those, and that's a very technical subject, but it's also very important for everyone to understand who's involved in making those decisions. So the third area of decision making is, how are you going to manage the resection? In other words, how are you going to make certain that the tissue that's been removed, the tumor that's been removed, has been removed with a clear margin of tissue around it? Because if you take someone through a fairly lengthy procedure, which involves a more risky outcome because you're perhaps harvesting flaps from different parts of the body, and then at the end of all of this, the pathologist tells you the margins are involved, then that patient may have to go back and have a mastectomy after all, which is not a good thing. So you need to consider some of the more modern ways of assessing margin clearance at the time of surgery. And there are a number of techniques which are available. Perhaps the most common type is doing frozen section, and I know this is done in hospitals here in Brazil. But for that, you need to have a committed pathology team, and you need to organize it so that the specimens are dispatched and received at the time of the surgery. Failing that, the other way of tackling this, and this comes down to the fourth domain, is you actually do your resection and then you wait for the results from the laboratory later on, and then if the margins are clear, then you go back and do your oncoplastic procedure to reconstruct the defect. And I think in clinical setups where the availability of pathology to do immediate reporting is not easy to come by, then the delayed approach is probably the most sensible one. And it also allows you to discuss with your colleagues exactly what you would regard as a satisfactory margin. If you do it at the time of surgery, then you have to make those decisions at that point in time. And then fifthly, if your patient needs a mastectomy because of the extent of the disease or the distribution of the disease, then you need to discuss with your patient whether or not they would prefer to have a reconstruction, and if so, whether that should be done at the time of surgery or at a later date. And there are factors now which are helping to decide whether the patient should have an immediate reconstruction or not. And one of the key factors is whether the patient is going to require radiotherapy after the mastectomy. Because if they are going to require radiotherapy, then by and large it's probably best to defer the reconstruction until the radiotherapy has been given. Because if you irradiate a reconstructed breast, as we all know, the outcomes, even with autologous reconstruction, are never as good as they are in patients who have not been irradiated. So with those people, it's probably best to get the cancer treatment out of the way and then to come back another day and do reconstruction with unirradiated tissue. And then finally, you need to discuss with your patient what kind of mastectomy you're going to be carrying out. And the two options are either skin sparing or skin sacrificing. The advantages of skin sparing mastectomy are that you tend to get a better cosmetic result with less scarring because you're reconstructing the breast within the uninterrupted skin envelope. So it's a little bit like putting jelly back in the mold. If you're doing a mastectomy without a reconstruction, then a skin sacrificing mastectomy will deliver a flat chest wall which will make it easy for the patient to wear an external prosthesis. So those two options need to be discussed and considered with the patient. And then finally, and this is a very big topic in its own right, is how are you going to reconstruct the breast? And we heard at the meeting today the different methods that there are, and the number of choices is going up. But what we do know is that there has been certainly a fairly major change in emphasis on implant-based reconstruction, particularly in the United States and now more recently in the United Kingdom, where I come from, because of a number of things. For the patient, it's a much quicker operation, it's one procedure, and usually one procedure, and a much quicker recovery, so you get back to work quickly at the end of their surgical treatment. For the healthcare provider, it's cheaper, and there's a much more rapid throughput through the theatre and through the beds in hospital. And for the surgeon, it's easier because the operations are shorter and the complications tend to be less, although there are some well-established complications, particularly infection, in relation to implant reconstruction. And that's why in the United States, about 85% of all reconstructions now are implant-based. In other healthcare systems which are publicly funded, you tend to see a different pattern. And I think here in Brazil, there's still quite a focus on autologous reconstruction in preference to implant-based reconstruction. And I think that's, you really need to have a balance. You need to be able to offer the patient all the options. And if you don't carry out that particular reconstruction the patient would like to have done, that patient needs to be referred to a unit where those reconstructions are carried out regularly. So this is a very interesting field, and I'm mindful of the fact that here in Brazil that the guidelines now for the profession are that firstly patients who are facing a mastectomy should be told about reconstruction, and more recently they should be offered reconstruction. And I think this is going to change the management of breast cancer for women in this country for the better in the long run. But there's a lot of steps between now and then as these techniques improve in their sophistication and in their outcomes. And the meeting that we've been at today, I think, has been very instrumental in bringing this together and producing a program of teaching and education which in the long run will make it much better for the patients under the care of the doctors in this country.